We're going to be talking about deep vein thrombosis, but before we do, I got to get the tunes turned down here. Figure out which window that's on. There we go. All right, so here we are talking about deep vein thrombosis. So a couple of key things for us to get. Number one, thrombophlebitis is another name you might see, inflammation of a vein associated with a blood clot formation. Includes superficial and deep, or we're going to calling this deep vein thrombosis, which commonly occurs in the lower extremity where we tend to see gravity-dependent blood stasis. And it's associated with Virchow's triad, venous stasis, so the person hasn't been contracting their muscles very much, not much movement, vessel wall injury, so there's local inflammation in the area, and they're in a hypocoagulability state right there, so they're more likely to form that clot. Now, the key thing is the deep vein thrombosis by itself is not usually that big of an issue because there's lots of collateral blood supply around these areas in the lower extremity. The problem happens when parts of that clot break loose, work their way up, and if we follow this, the greater or lesser saphenous vein, popliteal vein, not labeled here, but we can see the external iliac, the common iliac to the inferior vena cava, and eventually finding its way through the heart and into the pulmonary circulation, causing a pulmonary embolism, and that's the real concern right here. Realize that most DVTs are occult and usually resolve spontaneously without complication and are usually only detected when there is a coexisting pulmonary embolism that happens with it. Now, there are other causes for pulmonary embolisms, but this will be one of the key things that we have to worry about in our musculoskeletal outpatient practices. So demographics, 80 per 100,000, you have a 1 in 20 lifetime risk, so roughly a 5% lifetime risk, so not exactly uncommon. Usually 60 plus, the risk increases with age, of course, male equal to female. There seems to be some gender differences where you are Asian or Hispanic, you might have a lower risk, and Caucasian and African descent maybe 3 to 5 times higher in risk. Activities or risk factors that are out there are prior history of a deep vein thrombosis and over the age of 60. Do you smoke? Your risk is substantially higher. Are you obese? Absolutely. Pregnancy, not really a major risk factor, but the reason it's there is because that causes increase in venous stasis in the lower extremity, especially in the later stages of pregnancy. Hypercoagulability disorders, where you are forming clots on a more regular basis, immobilization of the lower extremity, whether that's casting, paralysis, bedridden, even long plane trips, sitting down watching TV for too long, you name it, in a movie theater, that can be risk factors as well. Surgical caused immobility would be the same thing, and malignancies, including past treatments within the 6 months, and we'll get into that in a little more detail here in a second. But those are your major risk factors. You can see here this Wells score for deep vein thrombosis. If you have 3 or more, you have a high probability of a DVT. Let me just go through the other stuff here. Estrogen therapy may also increase the risk as well. And this was one of the reasons there was a huge study being done on estrogen therapies that was stopped in the US because of the risk factors associated with this being too high for the benefits of the research. So assessment, what are you going to be doing? Realize most patients will be asymptomatic with this condition. So they'll actually have a deep vein thrombosis, but have no issue going on. If there are symptoms, or no issue presenting with you, I should say, presenting for you. If there are symptoms, they may have swelling in the calf. There might be some pain, deep achy pain or tenderness along the pathway of a vein. And you can see recent prolonged immobilization probably somewhere in their history as well, whether it's a trip, surgery, bedridden, even a tensor bandage that's too tight could lead to this as well. Physical exam findings only occur in roughly 10% of patients. Usually it is hidden. There's a test, I believe, that was taught pretty standardly called Homan's test. Dorsiflexion of the ankle, squeezing the calf, looking for that local tenderness. It has low statistical reliability and validity, not worth your time doing, and may even dislodge clots when you actually perform the test. There are better options. Unilateral, you may see edema or venous distension distal to the site of blockage if it's visible. Often these veins are too deep for you to see it because it is deep vein thrombosis. Possible pain or tenderness along the vein pathway, cord-like tenderness potentially, rarely pitting edema if it's a more chronic or severe case. Motion is usually within normal limits, other than the potential for the edema or enlargement of some varicose veins. Everything in the neurovascular screen is usually within normal limits as well. But this Wells score is what you should pay attention to. Active cancer treatment within 6 months counts for a point. Paralysis or recent immobilization is another point. Have you been bedridden for more than 3 days or had surgery less than 4 weeks ago, there may be clot formation as part of that scar tissue development there as well. Local tenderness along a venous pathway. So a linear line usually running inferior to superior. Is the entire leg swollen? Is your calf swelling 3 centimeters greater on one side compared to the other? Do you have pitting edema? Have you had a previous deep vein thrombosis? Do you have collateral vein dilation, non-varicose? So again, this can be tricky in our older patients who may have coexisting varicose veins. And is an alternative diagnosis likely? Then it's like -2 on this scale. But if you have 3 of these things, it's enough to think that somebody might have a deep vein thrombosis. Realize that it is often looked for but not found. In approximately 70% of patients with DVTs, an alternate diagnosis is usually found. Okay. If you suspect they have a DVT, look for other things. A detailed evaluation will save a lot of time and hassle for everybody. Alternate diagnoses could be gastroc strain, Achilles tendonitis, all of that. Homan sign is there, but again, I really wouldn't recommend it. Not sensitive or specific. Pratt sign, when you squeeze the calf muscle, basically this is just a deeper palpation, but there is no specific maneuver that you can actually do. You're better off because if you look at this gastroc strain and some of your other differentials, if you have any doubt, just send them for a diagnostic ultrasound. It'll show blood flow inside the vessel, has a sensitivity and specificity greater than 90 to 95%. And you could also look at it to rule out muscle strains and tears as well. Okay. MRI would be your best bet if you really wanted to have a good look at it. But at the end of the day, often overkill. You're often going to be looking at long wait times for that. So if you were in the hospital looking at an emergency event, then potentially you could do that. But realistically, most of us in our outpatient medicine, ultrasound is going to be a good choice. Contrast CT as well, but again, typically overkill. This is going to be imaging that requires a lot of intervention and time to do in specialists. So realistically, the ultrasound, just go with that as your best choice. If it has been there for a while, you might see a D-dimer test, but again, this is going to be that fibrinolysis that's taking place as the clot is actually breaking down. It's very sensitive, but it is not specific for this condition, okay? Yes, D-dimer. I'm not going to go through that blood test typically. And again, if you're in doubt, typically you're going to refer to a ER for this to be evaluated. General measures, acute, here I say it. Acute deep vein thrombosis is a medical emergency. The risk of actually having a clot and causing a pulmonary embolism can be substantial, and it can have a negative, extremely negative effect on overall performance for the person and even death in severe cases if a large clot manages to get all the way up there. What else do we see? Contraindications to treatment. Yes, you are not going to be giving vigorous exercise to increase blood flow, rapid stretching and physical therapy modalities. And of course, massage therapy over that area would be contraindicated for the potential of you breaking loose fragments of that clot. Okay. In chronic cases, you might consider compression stockings, medically supervised compression stockings. Ambulation would be key. Every time you contract your gastroc and soleus, even if you are stuck on a long flight, if you've taken anatomy from me, you know this is one of the key things that I say. Your gastrocnemius and soleus are like the second heart of your body. Every time you squeeze those muscles, they squeeze those veins in the area and help have cardiac return of blood flow take place. So even if you're sitting down, just contracting your gastrocs, if you're sitting down right now watching this, contracting your gastrocs, contracting your quads, all of that is going to increase the blood perfusion and blood flow and decrease your risk of deep vein thrombosis or clotting formation. Early ambulation after initial outpatient anticoagulant therapy is effective and strongly recommended. You have to be moving. This is a blood stasis issue. Prevention and education for your patient. Stop smoking. Never mind the risk for deep vein thrombosis, your cancer risks, your overall healing risks. We know smoking is killing you. Actually, sitting is also the new smoking and would be very relevant in these cases right here because prolonged sitting can also lead to it. Avoid long periods of immobilization and high resistance training like Valsalva maneuvers that cause venous distension potentially. Elevate the legs when you're lying down or sitting to improve venous return. This is a nice, easy, passive way for people to deal with this. Preventive anticoagulant therapy might be there for higher risk patients. Elastic stockings to keep the veins a little less distended might be a good idea. The prognosis is actually pretty good if they get the right treatment. So anticoagulant therapy reduces risk of mortality by 5 to 10 times. decreasing the risk of clot formation. DVT, the risk of chronic venous insufficiency and approximately 10% chance of pulmonary embolism that is fatal if left untreated. So do not miss this condition. Now, we know most of the time it's going to be something else. We have that previous stat about 70% of the time it's going to be another condition, but you have to rule out deep vein thrombosis if you are doing your best work for your person. And that is this process right here. And if you are in any doubt whatsoever, this involves an ER referral. So treatment for this one usually is going to be a medical ER referral. We are there to educate and empower our patient and make sure they get to the right place for the correct treatment as soon as possible for the best outcomes. All right, deep vein thrombosis, fantastic condition. Thank you very much for your time, and we will see you on the next video.